Hello, can you guys hear me now? All right, welcome, welcome. I see everybody getting on board here. We'll start in a minute or two. Please let us know you're here. Type where you're from and your name. We want to see who's with us today on our first training of the new year. We're really excited about this, so can't wait to get started. As everybody's joining us, please tell us who you are, where you're from, how long you've been a son. Tell us about yourself. We're excited. This is the first training of the new year, and we're starting off with what you asked for on feedback whenever we have tribal health. It's such a great response, and so that's how we wanted to start our year, is with your feedback for our trainings. And remember, we will do what you say, so make sure you put it in our feedback. We really want to make sure that these are meaningful, so I'm joining in. We'll start in just a second. All right, it is 11, so we have an action-packed day, so we are going to get started. Welcome all navigators. I know some of you are still our substance use navigators, and now we have behavioral health navigators, so welcome all navigators. For the best experience today, make sure you're connected to computer. We don't want you to run out of power. Close any unnecessary windows. Use the chat for questions. What's really important is make sure it's addressed to everyone. If you address it only to the panel or to me, I'm the only one that can read those. So we really want to make sure that your questions are addressed to everyone, because if you have a question, so does everybody else. Closed captions will be available, and this session is being recorded. Welcome to our Navigator Focus Series, Engaging Special Populations Tribal Health. This is our copyright. It's available under the Content Creative Commons. We just wanted to give you a very quick update with California Bridge. Our goal is to provide 24/7 high quality treatment of substance use disorders in all California hospitals by 2025. That goal is getting closer. When we first started from March 2019 to July 2020, we had only 50 hospitals, actually 52, if you guys remember. Now we have an update. We have over 160 hospitals in 2022, with additional funding coming this spring, summer, to make sure that our goal of all hospitals have MAT in their emergency room will be a reality. So we're really looking forward to this year. We're going to be busy and we can't wait. We're really excited. But right now, there's 160 hospitals. Before we get started, I did have one update. And remember, a couple of weeks ago, we challenged everybody to just get one new healthcare provider to get X waivered. So we want to continue that challenge. You have it till January 31st, and we won't be so strict, but we want you to tell us on Slack, send us an email. All we want is one. With 160 hospitals, if every navigator recruits one, that's 160 healthcare providers. We don't care. It doesn't have to be an ED healthcare provider. It could be a primary care. Just please accept the challenge. All we want is one. For those that you've done it, we have an incentive and we will be sending it soon. And we're really excited about this challenge. Again, 160 is our goal. So get out there and get your X waiver provider. Today's agenda, I'm doing the welcome already. We have many speakers, so I'm going to get going. These are our objectives for today. And we're going to start with Virginia Hedrick and with Tamika Bennett. And I'm really excited about talking about when we first started partnering with Tribal Health. I did not know what organizations. And so when I first started, I didn't know what Sakuya meant or CRIHB. And now I'm not going to talk about these people because I want them to explain who they are and what they do, because I think it makes more significant impact. So Virginia, do you want to get us started?
Sure. Squeanacoy, Naknow, Virginia Hedrick, Shregon, Mewamekchok. Good morning. My name is Virginia. I am the executive director for the California Consortium for Urban Indian Health. We call that CCUIH, and I'm also a member of the Yurok tribe, and really grateful to be here in the virtual space with you all, and thank you for the invitation. Tamika.
Hello, my name is Tamika Bennett. I am the project coordinator for California Rural Indian Health Board, Tribal Medication Assistant Treatment Program. I am so excited to be before you all, and I hope you all have an awesome time. All right, let's get started. Next slide, please.
So just quickly, some of you may have been in a virtual space, maybe even in an in-person space where you have heard conversations on land acknowledgements. And I just want to share, I don't have a formal land acknowledgement to share with you all, but just want to share that as a cultural practice for many Indigenous people, it's important to acknowledge when you're a visitor on someone else's land. And so I'll share with you this morning that I'm a visitor here on the Nisenan and Miwok territories. Really, I live in North Sacramento County, so really Nisenan territories here in Sacramento. And so as a visitor here, there are certain cultural protocols I would follow. It certainly wouldn't be appropriate to walk into another denominational church and begin praying or behaving in your different sort of church's behavior. And so I share that because we have more reference for that kind of behavior. And so as a form of land acknowledgement, I would ask you all to text your zip code to the number seen here on the screen. The link is also being put in the chat, so you could click this link. Sometimes when you click this link, like you lose your Zoom. So I share that with just the note, like try to navigate back to us and figure out whose Indigenous land you're on. Maybe you already know this, and I would invite you to put that information in the chat. It's very powerful for a number of reasons. One, it allows Tamika and I and Holly and others to know where you're at, where you're zooming in from. And two, it really breathes life into Indigenous languages, and it's important to see these names. It's important to be familiar with them and to say them over and over and over as many times as we can. And so, and then the third benefit to this is it lets us know as presenters, you know how to use the chat. And I really do invite you to use the chat, ask questions, make comments. I'm pretty good at multitasking, and so is Tamika. We're both mothers. I'm a mom of 5. So I can usually see what's happening in the chat at the same time and address it, but not always. And so it may be that when we're done, we circle back to some of your comments. It may be that we email you after, but really invite you to use the chat. Because it is the benefit to being in a Zoom space, right? There's not a lot of benefits. I really miss being in person, but I do see a great benefit to having continuous engagement during a presentation, and we don't always get that in an in-person setting. So let's use the small benefit that we get from being in a virtual. And thank you so much. I'm seeing so many beautiful places in the chat. So that's it. I don't want to spend much more time on this piece, and I invite you to use this as a strategy in future meetings or as you travel and figure out whose land you're on. So we can go to the next slide. So CCUIH is the organization that I work for. We work on behalf of 10 urban Indian organizations. That's a federal distinction. All of our programs are contracted with the Indian Health Service. And really the mission of CCUIH is centered around policy advocacy and public health programming. We launched a statewide MAT campaign a number of years ago, and it was my first opportunity to really dive into this world and try to better understand why we were not utilizing MAT in Indian country in the same ways that we have been in other communities. I've had some really tough conversations with some traditional healers, with elders, with young people, with family members about MAT, about its cultural appropriateness, about its potential inappropriateness, and have taken a lot in this process. I don't lead our work anymore, but I am just wanted to share that a little bit about these ongoing conversations that are happening for me in both my professional and workspaces. And so again, this is CCUIH. Next slide.
So California Rural Indian Health Board is a network of tribal health programs. It is controlled and sanctioned by Indian people and tribal governments. CRIHB is committed to the needs and interests to elevate and promote the health status and social conditions of Indian people throughout California. We do this on a number of levels, whether it's policy, education, promotion, public health, building a public health infrastructure throughout California. We have 50 plus staff that are locked into several different projects to support this infrastructure. And so before we do anything, a lot of our work starts with listening sessions and not to presume. And also understanding that each tribe is its own government. And as Virginia stated, being careful to, before assuming, but to know the traditions and customs before approaching. And more than anything with listening sessions, people will tell you what they require and what they need. And we do that in each and every meeting and engagement with any community. And it's starting with respect. So, next slide. So presented here is the representation. California is the largest state with the largest population of Native American, sorry, my notes, you guys. Native American population, and then followed by Oklahoma, Arizona, Texas, and New Mexico. Currently, there are 109 federally recognized tribes, and we have engaged throughout the years roughly 35 non-federally recognized tribes. There are a number more than that, but those are the ones that we have came in contact with. Next slide.
I think the only thing that I would add to this slide just quickly is the state population numbers represented on the previous slide were based on the 2010 census. And I can't not share this information because the 2020 census early counts shows 1.4 million people in the state of California identified as American Indian, Alaska Native alone, or in combination with another race. And it's just really the biggest testament to resiliency and perseverance. We saw our numbers double in 10 years, and that's been projected that our community and population is a very fast, young growing population. There are a number of ways that we could present data on where do all of these American Indian Alaska Natives live. And actually it comes as a surprise to many people that they live, work, play in a state that has such a large population of American Indians and federally recognized tribes. And one, I think American Indian people are invisible in many ways, sometimes intentional, sometimes unintentional. But of note is more than 90% of American Indian and Alaska Natives in the state of California live in what is a census designated urban area. So what you see depicted on this map is something I like to call a heat map. I think there's a more technical name for it. It's just how I call it. So where the number is darker, where the color is darker, you have a higher population of American Indians and Alaska Natives. And I always want to point out that you can make data tell you almost any story you want it to. And so I'm sharing with you that the vast majority of American Indian and Alaska Natives live in an urban setting, but so do all Californians. The vast majority of Californians live in an urban setting. And if we were to present this data in a different way and show you on a per capita level and sort of regulate for our more rural counties, per capita, the counties that have the highest population of American Indians and Alaska Natives would in fact be different. They would be Humboldt County, they would be Amador County, they would be Del Norte County, San Bernardino, Riverside counties. Those counties would per capita have some of the largest amounts of American Indians and Alaska Natives in those counties. Both are true, just different ways of looking at the same data. Next slide.
So here you have an overview of Indian health programs. What's not included in this list is youth regional treatment centers. And we'll be updating this list and making sure that we send it all to you. Roughly there's about 48. And that number is only increasing. There is a great deal of funding that's becoming available. And so I look forward to seeing this number grow. What's important to understand is if you look in the bluer area, those are areas of no existence of health programs. So people are having to travel such a far distance. So I think when people see the number and they're like, oh, there's 48 or over 48, that it's more accessible, but there is still a great number of people who don't have the access to reach health programs and still go underserved tremendously. And so, you know, as we begin to look at strategies and how to make sure that people have access to treatment, we need to also consider, you know, what does the terrain look like? Is there transportation, and all those other factors that go into building a health program in more rural locations.
Next slide.
So as I mentioned before, there are 109 federally recognized tribes. Unfortunately, several tribes were terminated and do not have federal recognition. And it's not that once they're terminated that they completely disband, because that is the representation of an individual's culture and who they are. And so they are still fighting to regain often that federal recognition. And some of them, as I mentioned, within the 35 non-federally recognized tribes that we've engaged, some of them fall within that category. Many tribes are currently seeking federal recognition. Sometimes there's a little bit of assistance and otherwise they're doing it on their own. So there's a great deal of advocacy that's underway. CRIHB plays a large role in supporting that. Sakuya is another entity also supporting that infrastructure and making sure that people are remedied in getting their federal recognition. Many tribal lands in California are small or isolated. And the reason why I wanted to make sure to mention that, again, when we talk about accessibility, it is not always to get to resources such as, you know, larger grocery store chains, medical resources, and a plethora of other resources. When we look at the difference between, the reservation and rancheria, the rancheria is more of a historical term. And so it may also be inclusive of several different tribes within that specific area. And then reservation is sort of the land and Virginia may have to help me with a little bit of this. It's the land in which the tribe, that's where they've been forever. So I hope that.
Yeah, I think the point here is just to say that in California, we have rancherias. We're the only state in the nation that has something called a rancheria. There's specific federal legislation passed to develop rancherias, and rancherias and reservations are the exact same things in terms of federal law, in terms of trust land, in terms of sort of being land governed by the tribe. So that's just a note of terminology. I think in our K through 12 public education system, we learn a lot about reservations and not so much about rancherias. Right. And so the cliff notes on this is that they function as the same.
And so I'll go really quickly to just really honing in on explaining a tribe can be a political destination, not always congruent with the people that make up the tribe. And so if you look at Susanville Indian Rancheria, the Maidu, Paidu, Pit River, and Washoe, and Pala Indian Reservation, Linsu, and Cupino. And then also Yurok tribe in Yurok, and then Big Lagoon Rancheria, Yurok, and Tuala.
Yeah, so that's just to say that rancherias by design often make up multiple cultural groups, and sort of the original reservations in California are typically just one language, one culture group.
Next slide, please. So sovereignty, inherited rights for federal recognized tribes to govern themselves. The U.S. government recognized tribes as domestic dependent nations, and tribes have their own governments, inclusive of health, education, housing, roads, public safety, and other entities, much like county, state, and government. And state government. What I wanted to draw from this also is, I will say within the last 3 years, I've seen an increase of funds being made available. And from my knowledge, this is the first time that large amounts are becoming available. Before, that was never the case. And so when we look at much of the work that we do with the Tribal MAP program and making sure that there are funds available to build out treatment programs, as well as education workshops and opportunities such as that, I hope that it grows even more because we will see the turn in the opioid epidemic that we're currently sort of like fighting through. And so I just wanted to make reference to that. So next slide.
So we have about 4 minutes, so I'm going to start speaking fast. And I just wanted to note that, as an accessibility issue, it may be difficult to track when someone's talking fast, so I apologize if this negatively impacts you. So as we talk about in the Indian healthcare delivery system, this is sort of the meat of it. It's a federal trust responsibility from the federal government to American Indian tribes, and by extension to tribal members, their children, and their grandchildren. In the United States, this is made up of 3 parts. IHS facilities, those are facilities that are funded, and all the staff within those facilities are federal employees of the Indian Health Service. Number 2 are tribally operated clinics. Those are tribal health programs who operate under the authority of the Indian Self-Determination Education and Assistance Act, Public Law 93638. They're often referred to as 638 clinics. In California, that makes up our entire tribal health delivery system. Every one of them are 638 contracts or compacts between a tribe or a group of tribes and the federal government. The 3rd tier of this are urban Indian organizations. And this urban Indian organizations are a testament to federal relocation programs that paid for and funded the relocation of American Indian people from out of the state of California and out of other states to large metropolitan areas like Los Angeles, San Francisco, Oakland, Sacramento, San Diego. And the trust responsibility then that follows that American Indian person from the reservation to an urban setting. In California, we have both tribal and urban facilities. And as Tamika mentioned earlier, only in the last 5 years have we had any IHS operated facilities. And those are youth regional treatment facilities, which I think is important to note for this group, that in the state of California, our only federally operated facilities are substance use disorder facilities, one in the north and one in the south, and they are for our youngest people. They are for 12 to 17-year-olds. And this is really a testament to California leaders and California tribes who advocated for these as being the single most important thing the federal government could build in the state of California was a youth regional treatment facility. And there are a lot of complications for why they're running well and some not running so well, but it says something about people caring about the next generation and really seeing this substance use disorder as being a high priority for our youngest people. Next slide. I'm going to skip this next slide. And I'll skip this. So as we think about the Indian healthcare delivery system, it's important to note that both urban and tribal facilities are by federal under ARA. We are equal to and the same as a FQHC, a federally qualified health center, which is sometimes a clinic can achieve that status by acquiring a HRSA 330 grant or applying in a number of different ways, but we are FQHC, both urban and tribe. So those of you who work in the healthcare delivery system will know that FQHC is a certain type of distinction, and you should know that tribal programs and urban programs are FQHC by statute. Next slide. The other thing that's really important to note when accessing or referring American Indian people to services within the tribal and urban networks are that there are specific eligibility to being an IHS eligible. And those are defined in a number of places. The Affordable Care Act, CMS has its own definition, and IHS has its own definition. Sort of the most restrictive definition is you must be a member of a federally recognized tribe. And then to receive services within a tribal facility, you either have to be a member of a federally recognized tribe or a descendant in the first degree, the child of a member of a federally recognized tribe. For urban Indian organizations, you can be the grandchild of a member of a federally recognized tribe. Those are really important. California also has its own unique piece of language in this law that speaks to California Indians and that significant amount of tribes that were terminated that Tamika mentioned earlier. So someone who meets the designation as being a California Indian is also eligible for services within IHS, both tribal and urban facilities. So we're going to run out of time, and so I'm not going to go further past this, but for the scope of this presentation, I think it's just really important that folks understand the full Indian healthcare delivery system in terms of where folks can access substance use disorder services. We also have 2 residential treatment facilities that are urban Indian organizations, an 80-bed facility in San Francisco and a 16 all-male facility in Manteca. And not every person who identifies as American Indian is going to be an IHS eligible, but they may be eligible if they're Medi-Cal eligible. And really, you can take a whole semester-long course on IHS eligibility and the way that the federal government has impacted the Indian healthcare delivery system. We're out of time, and I really want to save time for Holly and her team to present their section 2. So we'll stop right here. Thank you so much.
Thank you.
Thank you, Tamika and Virginia. I'm very, I'm sure our audience has some questions, and I'm going to let them know to put it in the chat, and we can answer. If they have any questions, we will chat back to you, or we will get back to you. Definitely, we will have your answers. We will get them to you. So please, we encourage questions. Type them in the chat. If you're on Slack them to us, because we want to make sure that you really know these resources. So I thank you very much for your time. I wish we had more time, but we have our next presenter. So what I'm going to do is we're going to switch, and I'm really excited because we have Holly Echohawk and Dr. Joan Condell, and I'm really excited because we've been talking, Holly, about this presentation for a while, and so without I would give their bios. I can definitely send that. I'll send all the bios when we do our follow-up, but I won't really want to give them the time because this is really important information. We just want to make sure that you guys have all the tools that you need. So without any other restrictions, Holly, I'm going to pass this to you.
Righty. Hi, everybody. Good to see everyone. And what a privilege to listen to Virginia and Tamika go over in very fast fashion the really fascinating history and tribal health system in California. And I know you all will receive these slides, so even though they weren't able to get through everything, that's rich information that they presented. So what we're going to talk about is engaging and supporting Native people. We're going to really kind of go into the emergency department with you. So next slide. And just Kaufman and Associates, wonderful organization. It's a tribal owned, all tribal technical assistance group. We have folks working all across the country. And our TMAT, California TMAT folks do live and work in California, and as well as our CEO. Next slide. So Arlene Brown, your former colleague, many of you know her, who was a son and then was recruited by Kaufman to work with us in the California team at work. She was going to co-present today, but she's sick. So I know you love Arlene just as we do, but she's with us here in spirit today, and she actually helped me develop some of the early slides in this. So, and then I'm Holly Echohawk. I'm from Oklahoma, that #2 highest proportion of tribal folk state. And I'm a member of the Pawnee, enrolled member of the Pawnee Nation. And we do our enrollment by blood quantum, which actually came from the way they used to determine the breed of horses, which is really weird, but true. And I'm a former behavioral health director, both tribal behavioral health and county mental health. And I lived in California a long time. I now live in Portland, Oregon, but I have lived in Humboldt County, San Francisco, Oakland, San Diego. And I used to be a member, a CRIHB staff person back in the 80s. So next slide.
Well, that's me. So I'm Joan Candell. I'm a family physician. I'm pinch hitting. I'm filling in for Arlene. No one can replace Arlene, and especially with her experience as a son. But I'm honored to be here. Thank you for having me. I'm a family physician, and I'm also an addiction medicine trained physician. So I'm double board certified. And I am in New Mexico, #5 on the list. But I'm from California. I spent half of my life in California. I was born in California, and my heart is still in California, but I live in New Mexico. I worked for the Indian Health Service for my whole career until a couple of years ago. And so I have a lot of experience working with tribal people, and I'm thrilled to be here. Thanks. Next slide.
So because she's pinch hitting, we gave her the big picture. And because she's so fabulous and so fun to work with and so cool experience. So this is what we're going to talk about today. We're going to love the Sakuya, our partner information. We're going to talk about how every encounter is an opportunity. We're going to give you some do's and don'ts about Native patient engagement. We're going to talk about emergency department patient behavior that you all have seen, and some underlying motivations to what you see sometimes, some of the behavior that you see. And we have a few resources. We also are going to show a video at the very end after the questions. So look forward to that close to the top of the hour. Next slide. Incredibly important for you all in your work in emergency departments across California to work in collaboration with tribal health services for all the reasons that Virginia and Tamika talked about. That's the UCLA emergency room on the top. And the bottom is one of my favorite places of where I lived, which is the United Indian Health Services in Humboldt County in Arcata. Beautiful building, very culturally driven in its architecture. Next slide. And Joan's going to do this one.
Yeah, so I think it's really important to hold this in your hearts when you are in the emergency department and encountering anyone, really. Every encounter is an opportunity, and especially with Native folks that you come in contact with. Yeah, I was, as I said, I was in the Indian Health Service for 23 years, and I was on the Navajo Nation and on the Jicarilla Apache Nation. And I, as a non-tribal person, I consider it such an honor to have worked so closely with tribal folks, and I feel that it was completely enriching for my life, just to be able to get to know people and to learn more about them. And their culture is very different from my own, but so welcoming and really wonderful. So every encounter is an opportunity. The more we encounter folks from other cultures, other diverse population of people, the better we are at dealing with people, and it increases our skills. and understanding the dynamics of differences. We'll talk a little bit more about that on a future slide. We can go ahead to the next slide.
So this is just some highlights about respecting Native people in the emergency department. You know, of course, you all are well trained and get experience every day in your work on helping patients, all patients, but in this case, particular Native patients, help them feel safe. And then also in your training, I'm sure, is to be humble, to be caring, to be authentic, to be calm. I think that's one of your mantras that you all have. But here's the thing about Native people. When you encounter a Native person in the emergency department, you know, or any patient, they're not feeling well, they're in withdrawals, they're afraid, they've lost control. But when you see a Native person who is what some people would call kind of down and out, don't think of them as that way. Think of them, look at that person and think, I bet you that's a brilliant person. I bet you that person has a ton of strengths. Now I just need to have to figure out how to communicate with them so that so I can learn more about how brilliant they are and what their strengths are and what incredible life stories they have. And along with that, the Native patient, they're the expert. They're the expert. They're the only expert in their particular life and their experiences. Our job is to figure out ways to communicate, to tap into that expertise that they have, and to, you know, really understand their needs. The other job that we all have is to reduce barriers to ongoing care. As Virginia and Tamika talked about, there's a lot of tribal addiction treatment services scattered around the state. We're going to help you connect with all that and develop some partnerships with the tribal and urban Indian technical assistance staff, which means CRIHB, Sakuya, Kaufman. Next slide. Well, this is a really important slide. This is one you might want to print out and keep near your desk. So how do you know if a patient is Native or not? So even though on the admission paperwork, it should indicate if they are AI, American Indian, or Alaska Native, it doesn't mean that and you all know this, that the emergency department folks actually look at that. They're in the ED, they're working on crisis, critical care. So they may not look at that. So then it's the now what for you all, now what? How do you find out if they're Native or not? What do you say? How do you ask in a neutral way? So here's our tips. Try this first. If you think someone's Native, you're not sure, sincerely say, are you Native? Most Native people will respond to that. Are you Native? Then pay attention to how they respond, or if they don't respond. If they answer yes in a welcoming way, then go to the next step. So the next step would be, do you mind if I ask what tribe you're from? That's a very respectful way to ask someone about their tribe. And it also is a way that gives the patient control. So they can control whether or not they're going to respond or not. If they respond and a welcome response, they say, I'm, whatever tribe they are, or tribes. Then the next step to proceed is, did you grow up here in Bakersfield or San Francisco or wherever you're at? Their response to that, if they respond, is going to tell you if that particular tribe they're from is local, or you'll get a lot of hints out of that response. So that's our tip for the day on how to find out if someone's Native if you're not sure. Okay, next slide. Native help seeking and help declining. We've been doing quite a bit of work on this, and we could do a whole presentation just on this. But basically, anyone that's in the emergency departments, there's a universal panic, right? You're there because something happened, something serious. You were brought by an ambulance, or you're in universally, regardless of race, color, creed, religion, people are in some kind of panic. That's universal. But for tribal people, that's further heightened by racism, discrimination, all their life experiences, past trauma experiences, not being able to communicate well because of a Native way of communicating is different than mainstream white way of communicating. And maybe they have a real additional panic because they would really prefer to see a Native provider, and they're in the emergency department and there's no one there that looks like them. So just keep that in mind. The next slide is Dr. Kendall's.
Yeah.
Do this.
So this one is really related to the last one. So this is a picture of an iceberg, the famous picture of the iceberg. And what we see in the emergency department is really the tip of the iceberg. There's so much under the surface. And this is a slide that we couldn't change this. If I could change it, I would not put non-compliant Native patient. So what you see in the emergency department is the quote non-compliant patient or the non-compliant Native patient. And I really like to not use that term non-compliant because I find it to be very stigmatizing and judgmental. And it's really, when you brand somebody, a person as a non-compliant patient, then you are judging them as having done something bad or wrong. And really that's not a healthy way to see somebody. So I try to stay away from that term. But anyways, so on top of the surface, you see this, someone, like Holly says, someone who's down and out, they're in a bad way, they're struggling. And underneath the surface are all of these other things that we have no idea when we come into contact with somebody. But there is little doubt that those things are there. Maybe there's mistrust of the system. Maybe they don't feel safe there. Maybe they feel discriminated against. Maybe they're having issues with housing or transportation or financial hardship. Maybe they've had past trauma in their own life. Maybe they've had intergenerational trauma that affects their everyday life. So there's so much under the surface that we can sort of uncover as we get to know somebody, but know that these things are all under there. So go ahead and advance one. Native behavior is often misinterpreted. The communication style isn't necessarily what you would expect. Sometimes people are very quiet, very reserved, avoiding eye contact, and really important to think about that and not misinterpret that as being not intelligent or being suspicious or being something. But that may just be a cultural norm for people. Maybe they are being respectful by not looking you in the eye. Let's go to the next, click it again. So this is interesting. So different standards when calling for security. This was Arlene's example, and she has seen it, and many of you may have seen it as well. So click one more time. So if in the waiting room of the emergency department, you have an angry white man versus an angry brown or black man, there is a difference in the like how quickly one would call for security. And this is just racism, plain and simple. People would tend to kind of talk to the white man and try to calm him down.
Mm-hmm.
But if people see a brown or black man in the waiting room being very angry, irate, call security, So just wanted to point out
Mm-hmm.
that dynamic.
Right. And we want equity in terms of de-escalation.
Yeah.
Not just an automatic response because somebody brown or black and angry,
Yeah.
Call
All right.
security. And de-escalation, as you all know, and are probably well trained in, is important for all people equally. Okay, next slide. We have just 4 slides left. Okay, this one is ways to engage Native patients with inclusive signage. So we'll click one more time, please. So one of the things, buttons in your work are really important, and they're super important in terms of just messaging. But if a button is indigenized, as Arlene has done when she was a son and currently, it's hugely important. It is for a Native person in the emergency department to see a physician or a nurse or a son, and they have on a pin that has beadwork around it, you have instantly brought down their anxiety. They may instantly see, they may not know you, but they're going to think, this is something here because this person has on a button that has Native beadwork on it. So all of that we've all heard about and know that how important it is to have culturally engaging information in waiting rooms, in the emergency department, signage, critical, really super important. And it's such a simple thing to do. Next slide, please. So here's some other buttons and name tags. We just want to give you some ideas about that. And again, this is courtesy of Arlene Brown, and it's just really important. So we also want to share with you some, we just have a couple of slides left. What can you all do outside of the emergency room? How can you get out in the community and really connect with the tribal populations in your area? There's several things you can do. If you create local coalitions, be sure to include tribal health programs. All of these things you can constantly do. But the most important one I wanted to speak to is the last bullet. We're going to send this to you in a separate email, because we're going to send you the list of all the tribal health programs that Kaufman works with. We work with 7 that are developing MAT services, and we work with 15 others that are working on integrating traditional practices into conventional substance services. And we do that with Sakuya and CRIHB. But we're going to send you by county, so you can look up the county you're in, and then we're going to give you the tribal TA person's contact information, so you can connect with them and vice versa. And then they can help you, if you don't already know tribes in your area, they can help you develop those partnerships. They can introduce you. You all could work together on ways to destigmatize MAT in tribal communities and all kinds of different projects. But we're going to send that to you separate because it's kind of a long list. And then the last slide, next to the last slide, is resources. So we can go to one more slide. So there are many resources, but we wanted to give you 4. One is UCLA is doing another tribal health provider training in February with Dr. Jeff King, who's Muskogee Creek tribal psychologist. And the presentation's going to be great. There's not a link there because UCLA is just releasing those links, I think, today or tomorrow. So we'll make sure you get that information. Those are 2-hour training sessions. And then next Tuesday, the launch of a new tribal behavioral health echo series is starting for the full year 2022. It's 1 hour, once a month, and it's under the umbrella of reclaiming Native psychological brilliance. So we want to give you the link to that, which is next week. And then in addition, next week, Northwest Portland Area Indian Health Board, our good friends and colleagues, they also have a behavioral health echo and their echo is once a month for 1 hour. It's noon to, I believe it's noon to 1 every month. And that's a link for that one. The difference between the 2 echoes is the Native psychological brilliance is reclaiming Native tribal psychological brilliance. When you click on that link, I think it'll tell you the series of the topics for the month. There's no case reviews in that one, but in the Portland one, they do a clinical case review each month. So, but they're married. They were sister brother connected. And then the 4th one we wanted to leave you is the dictionary. We use the dictionary all the time. I love that resource. Many of you may already have it, but in case you don't, we gave you the link there. And the thing about it that's super cool is if you look at it, it has stigma alerts. So if there's certain words that are not good to use because they convey a stigma, they have a little stigma alert by those words. So it's in alphabetical order. It's really a great resource. In case you don't have it, we wanted to be sure to include that. And then the last slide that we have is just saying thank you all so much for listening to us. Be safe. This is a kind of a silly screenshot that we did around Christmas. There's Arlene in the top right, even though it's not a great picture of her. And Nancy Pierce, one of our other TA folks that you'll receive information about in a separate email with our other TA staff. But I want to use this because I want you to see that even a cookie, even a sugar cookie can be a message. So Arlene made these sugar cookies. It's reversed in the mirror, but it's about Narcan. Narcan saves lives, and she put them on top of these sugar cookies for a community event. So that's what we have to share with you. We hope it was helpful. It's so fun to be here with you guys. And we're going to move into questions and answers, I think.
Thank you so much for the tips. And Dr. Kendall, if I could just ask a question, how is the feeling when you talk about MAT specifically, medication? Is that something that they're, Native Americans are open to? Is it something that really needs to be explained? Are there any key words when talking specifically with MAT?
Yes, thank you for asking that. My experience has been that people are very open to talking to me about it. It would be, I talk to people about it in the same way, regardless of whether they're Native or not, in terms of MAT. Some people are open to it and some people aren't. And it's just a matter of, just like with anyone else, feeling it out. If they do, really trying to do motivational interviewing and try to see what's motivating them to either seek help or to decline help. Holly mentioned the help declining. I would say that is a big issue for Native folks. They have a lot of hesitancy to accept help. And so it may take a little bit more time with Native folks, a little gentler approach, and just giving them the information, letting them seek the help and know that they're in a safe place. So I would say that is one of the differences. And it really is across the board. Some people already know about it and are just like, yes, I just really need you to prescribe that for me. And some people are like, I don't know about that. I'm not so sure, and so it's really across the board.
But there's a cultural piece to it as well. And that is that tribal people, especially decision makers, tribal health board, tribal leadership, someone in their family has gone through sobriety, almost always, maybe themselves. And they've done that through an AA route or a tribal equivalent of AA. So there's real confusion about sobriety and is MAT violating that. The way we explain that to folks to make it much more understandable is that the advances in drug production and the lethalness of drugs now puts everything in a different world. The damage that it does to people's brain is very different. And so we need modern medicine in addition to traditional beliefs. Those two things combined are really important, that the world's changed and the lethalness of drugs has changed and the damage to brain is different. So just a sobriety movement alone for the addictions that we're talking about is not enough. So that's how we tend to explain it, but there is a hurdle to get across for some tribal folks on that sobriety issue.
Thank you. Yeah, that's exactly, I'm sure our sons are experiencing that. I do have a question regarding the beads. It says, is it not seen as culturally appropriative to include Native bead work? I just do not want to offend anyone when my intent was to be inclusive. You
mean somebody that's not Native to wear
right.
And that had bead work on? No, I don't think it's, there's no cardinal sin.
Okay.
And I think that it's all about some of the tips that we talked about, being humble, being authentic, being sincere, saying what you don't know you don't become a tribal expert just because you have a pin on. But immediately the visualness, and maybe Virginia has something to chime in on this, but the visualness makes a difference to a tribal person. They think that's an ally, that's somebody I can probably trust. And then you have to take it from there.
Great. I like that.
I see
like
Virginia's nodding her head, so I thought something to add.
We have somebody from Spokane, Washington. Are there any resources or contacts in Washington state of Spokane? Is that something you can help with, Holly?
Yeah, our Kaufman and Associates is based in Spokane, Washington.
Awesome.
That's our headquarters. And when we send that list, Debbie, we will make sure that we link you up with, you'll see the list and you'll see, we'll give you a contact person's name and how to connect with them.
Great. Thank you so much. Thank you, our whole panel. We have your video that I wanted to share. Let's make sure.
And while she's getting that ready, let me just tell you a bit about it. It's called Natives for Narcan. It was developed by the Bakersfield American Indian Project, and Arlene Brown is a big part of getting this developed. So we just have a couple of minutes of this we want to share with you all.
As a tribal councilwoman, it is important for our tribe to have Narcan available at all times. Having Narcan readily available to administer means that a person who is experiencing an overdose has a much greater chance of surviving and getting the help they need.
I carry Narcan, so another family doesn't lose a loved one.
My little sister died of an overdose. I carry this so that yours doesn't. I carry Narcan for my people and for my culture.
Manahu, Inaniana, Jasmine Dondera. Yeshit Nidu, Miss Bishop Paiute Tribe 2020-2021. Hello, my name is Jasmine Dondera, and I'm Miss Bishop Paiute Tribe 2020-2021. Overdose death is preventable, and it's everyone's job to watch out for each other.
That was great. I love that. Your videos always just make me happy. They're always promoting something wonderful. So I really think that this was just such a beautiful video, and it goes with all of our beliefs as sons that everybody should have Narcan. So I always thank you. This is such a great partnership, you guys. I really want you back. Hopefully when things get better with COVID and we have our in-person, we definitely want to collaborate more. I know there's so much to say with such short of time. So I really thank you for being here. If there's any questions, please do not hesitate to put it in the chat. Again, we will answer all calls. Definitely. I just want to make sure that, again, you guys are always welcome back, 100%, just to let you know. So you are truly a great collaborator. This was so much fun. I'm just going to give you some announcements. We have our navigator update now. We have a new format, a monthly interactive meeting. It's a half an hour. A regional director and some mentors will be discussing trending topics. And most of the topics are coming from our advisory council. So they're really good discussion. Our next navigator update is February 9th at 11, and Josh Lefting and Christian Hilosian, our SEM mentor, will be presenting. And you know, Josh is our Narcan expert. And so I can't wait to share this video with him, Holly. He's gonna love it.
Mhm.
I can't wait. Our next training is part 2 of engaging special populations. And, you know, Holly talked about that today with racial equity for, you know, Native Americans, as well as for homeless and undocumented migrant workers. So we're gonna have part 2 February 24th at 11, and we will share that link for registration. That will be part 2. Charles Hawthorne will be presenting. Just wanted to remind you, we always have our Sun Mentor team, and I'm so excited because we have Angela's picture this time. So I'm glad Angela we've updated New Year in 2022. All of our mentors, we cannot do this without them. They are such a crucial, vital force for our substance use navigator program. And I thank each and every one. Join us on our website, as well as Facebook, Twitter, Instagram. Again, my name is Sherry Cisneros, and I am the SUN program director for California Bridge. And always remember, addiction is not a moral failing. It's a chronic disease that requires medical treatment. And I leave you on this this platform because there's so much work to be done. You know, we're constantly striving and trying to win this war. And I thank you on our panel on behalf. We are honored to have you here today. Again, they want the contact information, and we also will send their contact information with the slide decks in our follow-up letter. So do not worry if you didn't get it in the chat. No worries. We will send an email with all of the information. So no worries. Thank you very much. And we will see you next time, guys. Can't wait to meet again. Bye-bye.
Bye. Thank you.
Bye, everybody.